everybody. Katy Lees here, Principal 340B Compliance Advisor with Virtue 340B. Welcome back to Katy's 340B Compass. Today I was going to talk, or am going to talk about a few things that have come out in the past week or two that could make some really big changes within the 340B world. So, as I was thinking about making this, I had I'll say a funny thought. It's really not funny, but, over the past, I'll say a year or two, but probably longer, I've stopped talking about work so much with, in my personal life, like with family or friends or whatever, because, I feel like for a long time, as things started to escalate, I was always talking about how crazy work was and how it's just getting worse, and would talk about what's happening. And that escalation has not stopped. And so I just stopped talking about it, because how could people possibly believe that things still are just evolving in the way that they have been, and really not ever in a positive manner, or not in a long time. So it's sad. It's crazy. And those of you listening know what I'm talking about, because you live it as well. And I'm going to talk about three things today that could add to that. Maybe there could be something in there that could help. I don't know. I'm going to start with the CMS OPPS proposed reimbursement for January 1st of 2027. We got a glimpse of this, I believe, at the end of last week. We saw that as a result of the acquisition cost survey, which I think most of us know how that went. CMS is proposing that reimbursement be changed as of January 1st for 340B transactions from ASP plus 6% to ASP minus 33.4%, which, oh my God, I really hope that isn't what happens, because if anyone that is in the hospital space I guess you don't even have to really do any work or run any sort of analysis to know the significant and just terrible impact that is going to have on our healthcare system. So hopefully that's not what actually goes into place, but we certainly have some work to do to, ensure or hope that that doesn't go into place on January 1st. So, if those of you that have been around for many years, you will remember that in 2018, CMS changed the reimbursement for certain hospitals that participate in the 340B program from that general ASP plus 6% to ASP minus 22.5%. So what's that? 28.5% decrease. This time we have a 39.4% decrease. It was so detrimental the first time. And, those, again, that lived through it know that it was something that there was a long dispute on whether CMS was permitted to make that type of change. Ultimately, the Supreme Court ruled that they did not take the appropriate steps to change reimbursement in that way. So they had to recall that and are still in the process of repaying all of the reimbursement, or the reimbursement that they should have been paying at the standard rate during that. I think it was about 4 years that went on with that lower reimbursement. And so now the steps that CMS was supposed to follow is to do an acquisition cost survey and then use those results to propose new reimbursement. Not sure where ASP minus 33.4% came from. That definitely leaves, I might say most drugs, definitely many drugs, underwater at the 340B price. That does not cover the cost of the drug. So I can't imagine that's truly what our government wants to do. I would like to think that is not their intention, to just completely devastate the safety net hospitals of our country. But I guess we shall see how this evolves. Obviously, it is very new. I will say, while we can just say conceptually how devastating this would be, it's very important if you are, working at, for, or are, partnered with, support a safety net hospital that will be impacted by that, which is essentially non-rural hospitals will be subject to the proposed reimbursement. Then, take the time, do the work, do the analysis, use that information to tell your congressional leaders what this impact would be for your organization. Be sure to respond to CMS's request for comment on these proposals. So very important to do this. Certainly this is, the type of analysis that we at Virtue 340B can help with if needed. I will say at a high level, if you have access to charge data, what I tend to do is, it's really hard to get actual reimbursement data. And a lot of times, there's other things in the reimbursement. I mean, not much, but, not just the drug. So I like to use charge data, drug charge data, apply what the expected reimbursement is, go to CMS, download the addendum B. The most recent one is for July that has all of the payment rates, which that payment rate, I believe, and theoretically, is that ASP plus 6% rate. Apply that to your current charges. That should be what you're being reimbursed today. There's many other factors. I am oversimplifying it, but I mean, to get it done, I think if you've been with me for a little while, we're saying let's not let the strive for perfection prevent any sort of progress, because this could be made complicated, but I think to get an idea, a high level of the impact, we can think about it somewhat simplistically, applying that payment rate across all of your charges, and then, do the calculation to transform that payment rate into the ASP minus 33.4% to then see, what would that reimbursement look like in that proposed future state. If you also have your drug costs there, you're definitely going to want to do a comparison and see what today's margin is compared to that potential future state margin, because it's ugly. It's really, really ugly. And, even the option of, okay, so is that just going to force hospitals to largely carve drugs out of 340B to still get the standard reimbursement? I think we all also know that the standard reimbursement isn't going to cover those drugs at wholesale acquisition costs most of the time. So do that work, though. Certainly should have that information in your pocket as well, so that you have this information. You can share it with whomever would be most important to know this information. Certainly, if you're watching and you're a part of the pharmacy department, you should be sharing with your leadership, sharing with your government relations team, sharing with your congressional leaders. Like we always talk about, we have to keep everyone in the know. This is not like a siloed world where one person should be responsible for 340B or making decisions or bearing the weight of this madness. Make sure that everyone at your organization is aware of what's been proposed. Most likely they are, and they're probably already asking you, what does this mean for us? So that's very important at this time. I should know, I don't have it in front of me. I didn't put it in my notes of what the comment period would be, but I suspect we have, I think it's until sometime in August, we have to submit those responses on what we think about these proposed reimbursement changes. I'm not sure what that will mean if we actually, us sharing those opinions. They seem to be falling on deaf ears quite frequently lately, but still get it on record. So it will be very important to understand everything that will entail. The next two things that I was going to talk about are the two pieces of legislation that were recently introduced. One by Senator Cassidy, and then the other one by the new group in the House, which is kind of the complement to the Gang of Six. In the Senate, this is the group, which I think it might just be a group of four. Again, I don't have all of the names in front of me, but still, it's been a great effort. I have spoken before about my respect for the group of 6 senators that have been working on the Sustained 340B Act. Granted, it's been a long time coming and it hasn't necessarily been introduced yet, but I know they've put a lot of work into that. It's a very comprehensive legislation. It comes with a lot of good. It comes with some bad. We know both sides have to compromise, but I think that in all, that would be great legislation if we ever see it. And I've seen an old version. I'm not even sure what a new version looks like. So I guess I should, officially hold my opinion, but I certainly respect the work, the time, the effort that has gone into that. So now we have a group in the House that has just, popped up and passed the Gang of Six in their efforts to develop their own comprehensive legislation, which is in a lot of ways similar to what the Senate group has been working on. It has a couple key differences, again, based on at least what I last knew of Sustain 340B. The new Secure 340B Act, so that is the draft legislation or the legislation from the House group. It stands for Strengthening the Exercise of Controls and Upgrading Requirements for Efficiency in 340B Act, also known as Secure 340B Act. So it has, like I said, it touches on a lot of things. There is a lot to unpack there. Definitely take the time, read through it again, understand what these things will mean for your hospital. I will say I'm going to try to be like somewhat unbiased because I certainly have my opinions on the legislation. But take the time to just really understand. Don't absolutely I don't think we should absolutely love it to be, just take it all in and I'm 100% on board, but definitely I also don't want people to just be like, oh, nope, that's a deal breaker. I could never, that's just, I think that we need to think about the good that it could bring. And, maybe we definitely have to compromise if we want to codify these elements of the program so that maybe we can find some stability. We have to compromise. We have to be willing to change some things, maybe lose a little bit. And we'll definitely have to add some work for, transparency and reporting. But again, I think that there's potential for it to be for the greater good. I don't know if this product in its current state is what the safety net community will be willing to adopt. I don't even know if it's what the pharmaceutical industry will be willing to adopt. So, I guess there's probably a lot of time that we're going to have to talk about this before it's truly going to be, voted on as a law, if it even gets to that point. But it's certainly, I'm going to say it's progress. I think it's a good development. We need something. We need something to bring some stability to the program. We need to stop just fighting everything in the courts. We could use some real rules that people can point to, people can feel confident about, and can just kind of silence some of the madness. So just a few of the highlights for those of you that maybe haven't read through the details or seen any of the summaries reported. They're defining what a patient looks like, and I don't necessarily think it looks a lot different than what I consider the patient definition to be. A patient has to have had a visit, an encounter within 2 years with the organization. The provider has to be employed or contracted with the organization. There is room for referral prescriptions, but they are limited to certain entity types, rural hospitals, and I think FQHCs or some grantees. I have some notes here. It does reinstate contract pharmacy access. It does not have limitations on contract pharmacies by number or number of contract pharmacies you can have, a hospital or a covered entity can have, or it doesn't have geographic restraints. It does have new reporting requirements. It has a new approval process where the pharmacy service agreement has to go to HRSA for some level of review. I will say that one of the things that stood out to me as I read through this is it's a lot of new work for HRSA. It's a lot of new work for everyone. I'm in my head, I'm always thinking about how things will work, how things will actually in operation, or is this feasible? Is this realistic? And not sure that I feel that way about, some of these things, these new tasks that are being assigned. There is some new, probably I will say the most controversial thing from the safety net provider side is there's a new, I'll call it a layer of child site eligibility. So for the most part, it's still sticking to the cost report requirements, which again is proving that provider-based status and integration with the hospital. But then there's another layer or level of parameters that each child site has to meet this SVI ranking, which social vulnerability index. It's a very interesting website. If you go on the SVI website, there's a map. You can zero in and go by like the whole country, by state, by county. Like, it's very interesting. So that read through that part. Again, I'm not going to get into all the details, but that's definitely something that hospitals are going to want to look at. And that's the one that I'm really saying, like, don't just completely discredit it right off the bat. Like, do the work, look at the data, pull your child sites, go to the SVI website, pull that, the reporting that is available to see, it's basically if the child site is in I believe it's by zip code of their SVI ranking. It has to meet a certain threshold. Otherwise, it doesn't qualify based on that. But there are a couple other layers there too. It depends on the services provided. Potentially something at the patient payer level, but I don't believe that is included in there. But again, that's where it's important to do the work before that part is like, somebody, if you say, oh, nope, that's a deal breaker, I'm done. Make sure you understand exactly how that would impact your organization, because I think you'd be surprised. Like, it's not perfect. It's certainly, again, that will be the controversial part for safety net hospitals. But it's worth reviewing and really understanding how it will impact each organization. There's a bunch of language and requirements on financial assistance, how hospitals can handle bad medical debt, a bunch of transparency requirements, program integrity, expansion of audit requirements. The most interesting thing is that they are proposing a clearinghouse, and that the clearinghouse be given 4 years to be implemented and proven effective, or maybe proven ineffective. I'm not sure. There's certain benchmarks that the clearinghouse needs to meet in that 4-year time frame. And in that period, rebates cannot be introduced. So basically, there's a 4-year prohibition on a rebate model being introduced. And then assuming that the clearinghouse meets those benchmarks and satisfies, what the transparency, duplicate discount prevention, all of those things that are laid out, then the clearinghouse will still prevail, and rebates, that the prohibition would carry on. Now, if after 4 years, the clearinghouse is not meeting those benchmarks and, it's just not satisfying the objectives, then it is possible at that time that rebates could be introduced. So again, when I talk about we got to look at the good and the bad, like if you're a safety net provider, I think that's a really big good one. Along with the contract pharmacy codification, it prohibits discriminatory payer and PBM practices. So no discriminatory reimbursement, or I will say, I'm sure it's not none, but it will certainly make it very difficult for discriminatory reimbursement. Unfortunately, I don't think that applies to the government as the payer, but it might apply to those managed care plans that follow suit. So that could also be immensely helpful. And there's a new user fee that would fund HRSA, because as I said, there is a lot of new work that HRSA will be doing under this new legislation. But there's so much to dig into. Definitely need to read through it, understand. Again, it's going to take more than one person at your organization to even understand what the impacts would be. I know, when we talk financial assistance or how medical debt protections are in place, things like that, like that's not something that I can necessarily read this and understand how it would impact any given hospital. Like that's something that people in financial services or other areas really need to also look at this legislation and kind of comment on their thoughts on what that impact would be on an organizational basis. Now, if we go to Cassidy's bill, which I would like to spend less time on because I certainly feel less positive about this one. This is the 340B Drug Pricing Integrity and Affordability for Patients Act, which I'd like to think that Senator Cassidy has good intentions and that he truly thinks and believes that the program needs reform. And I mean, it needs some sort of reform. I can't disagree with that, because we need to find a place where we're not just in constant like chaos and can't plan and can't function as a business, because again, these healthcare organizations are a business and we really need some stability. But this is not the type of reform that our healthcare system needs. In contrary to the secure 340B, this legislation makes rebates a central policy option. So manufacturers may make the ceiling price available through either an upfront discount or retrospective rebate. So, and there's a lot more to that. Again, I am just going super high level. So please spend the time and look into what each of these, policies mean or legislation mean for your organizations. It creates a secretary operated claims repository option. I would think that that's very similar to the clearinghouse option. Defines standardized claims data in detail. It also codifies patient definition. I don't know that that's going to be as comprehensive or supportive of safety net providers as we saw in the secure legislation. It allows contract pharmacies, but with significant limits. It certainly puts a lot of caps on those arrangements. It requires new contract pharmacy compliance procedures and written agreements. It also includes more targeted transparency and reporting, and also touches on what hospitals are required to establish in regards to sliding fee scale and things like that. It also tightens hospital child site eligibility. I'm just reading through it a bit. Certainly, I think it has even more limitations than we talked about with the secure 340B. And then it has some language about new requirements on TPAs and just payments, so like dispensing fees that can be permitted in contract pharmacy arrangements, which actually I didn't mention. I'm pretty sure that the secure also includes some parameters on those TPA and contract pharmacy dispensing fees. And then also just has some new language as well about the prime vendor program. As we, I think, have seen from Cassidy in the past, he is certainly following the pharma lead. Like, he is listening to everything they have to say, and I have to believe taking it as fact, which there's a lot more to that story most of the time. So I think that's the most troubling part, is that even if he has the best of intentions, this is built on a lot of misinformation. The need, his seeing this need, this type of reform, it's not based on the facts. So I hope that this is just more messaging than anything else. That's what a lot of people are believing. I mean, like I said, it's very likely that none of this is going to move anywhere, but we hope that this gets zero traction. Just looking at the comparisons, I mean, the biggest things, like we talked about, is one is very pro rebate and one has a prohibition on a rebate policy for 4 years. The child sites, the contract pharmacies, there's just so many differences between the two. So please do your homework, talk to your, your government relations team, your congressional leaders, tell them how you feel about both. Like, you certainly don't take my opinion. Read through them, and however you feel, wherever you land, I guess it's important to, talk about how this would impact your organizations and your communities, because these three things that I talked about today, like, I can't even fathom, the impact. Again, just that the OPPS, if that rule goes through the way it's been proposed, I'm kind of fearful for healthcare in 2027 and beyond. So, and then I'm not even going to let myself believe that, Cassidy's bill is going to have enough traction to become a reality. I'd like to believe that, Sustain and Secure they have the potential to improve the 340B space. Are they perfect? No. Hopefully it's, maybe it's just a starting point where we talk through and the concerning parts, and we find a place where we can all land and feel comfortable and, just codify some of these elements of the 340B program so that we can have a little bit more sustainability as we move forward. So yeah, it's always interesting times, and I appreciate you joining me today, and I will talk to you soon. Bye. Do you have a 340B compliance question? Send us a message at virtue340b.com. Thanks for tuning in, and we will see you on the next episode for more expert 340B advice. Talk to you soon.